Hi everybody, and welcome to our pre-recorded talk for the conference. I'll just start with my disclosures. Avelumab data in the Cell paper was carried out with Merck KGaA. Some of this work is covered by UQ Patents, where I'm the named discoverer. And we're also in discussion about working with Telix, who are also sponsors of the conference. So upfront disclosures. So I'm going to discuss a PhD project done by one of my excellent students, Benedict Lum. And I'll start with the background from one of his talks and then go on to our new data and futures for this work. So we were looking for new therapies to treat the rare cancer adenoid cystic carcinoma. ACC is a rare cancer of the head and neck, develops from the salivary glands. It's indolent but persistent. And while the 5-year survival rate is quite good, the 10-year survival rate is not, especially where perineural invasion and spread are common. So the pathology of these patients is they tend to come with a slow-growing tumor that's removed by surgery. Sometime within the next 5 to 10 years, that tumor grows back, becomes rapidly aggressive and metastatic. And so for these patients living with the disease, it's like living with a time bomb. And there's currently no targeted treatments available for adenoid cystic. So we've been looking at prostate-specific membrane antigen as a potential target in adenoid cystic carcinoma. So immediately you can see from this that prostate-specific membrane antigen is not prostate-specific. PSMA expression analyzed in adenoid cystic tumor showed a 94% expression. It's highly expressed with a median of 31% positive cells, and it's expressed importantly both in primary tumors and the metastatic secondary tumors. And some of this was picked up incidentally by PSMA PET in prostate cancer patients who also had adenoid cystic carcinoma. You can see here PSMA positron emission tomography PET with gallium and fluorine, 68 gallium and 18F. And this is a 73-year-old patient with recurrent prostate cancer, whereby you can very clearly see all the metastasis throughout that patient. There's also a phase 2 study for PSMA in adenoid cystic carcinoma patients, and that's being carried out with 68 gallium. And again, as with prostate cancer, this is an attempt at therapy in targeting adenoid cystic carcinoma with the standard radio-ligand therapies as well. So the basis for this work is here, but it requires improvements because even though, as you can see from homegrown PSMA PET here at the Princess Alexandra Hospital by our clinical collaborators, locally, regionally recurrent adenoid cystic carcinoma with gallium-68 PSMA PET is very easily detected. So from an imaging perspective, this allows for better surgical planning, because in comparisons, the metastasis in the areas of spread are much clearer to see than standard imaging for adenoid cystic carcinoma surgical planning. And so the MDT has actually moved, whereby all adenoid cystic carcinoma patients can now be imaged in this way, and that allows for better clinical planning of the removal of metastasis. However, in various trials targeting PSMA, we know from prostate cancer that there's a level of PSMA, a PSA waterfall plot, whereby you need a certain amount of it to get a response to these radioligand therapies. So with 177 lutetium PSMA 617 and other trials, the data put together has actually set a cutoff for admission to trial, whereby you need an SUV max greater than 15 on the initial PSMA PET scan to even benefit from the therapy. So what we've been looking at is, can we actually upregulate the expression of PSMA above this delta CT max of SUV max of 15 in order to allow more people to benefit from clinical trials and therapy. This isn't just applicable in prostate cancer or adenoid cystic carcinoma. As you can see here, PSMA is a very actually widely expressed ligand, and it's present in a number of cancers which are a problem to treat, including things like ovarian cancer, cervical carcinoma. And PSMA is a good target because it's a type 2 membrane protein that sits very much exposed on the plasma membrane. However, that plasma membrane exposure is temporary because PSMA is internalized inside the cells, especially when it binds ligand, by clathrin-mediated endocytosis, as you can see in the electron microscopy here. Antibodies and therapies can increase that rate of internalization by threefold. And if the PSMA is then directed to lysosomes for breakdown, which is what the purpose of the clathrin-mediated pathway is, then the cells are able to clear the target of the therapy from their surface. So here you can see in an experiment that using a point mutation in dynamin K44A, this point mutation prevents these clathrin-coated vesicles from actually leaving the plasma membrane. And so the cargo gets stuck there. And as you can see here, the PSMA is then trapped, exposed on the plasma membrane, and can't be taken inside the cells and broken down. So there's a number of current PSMA-based imaging and therapy options. We have the small molecule ligands, but also potential monoclonal antibodies like J591, which has now been developed by Telix as J592, and that's a potential for therapy in multiple ways. So why are we involved in this? We, not very long ago, published a Cell paper showing that in clinic, we can inhibit dynamin, the same molecule as that point mutation, using high doses of prochlorperazine, which Australians know as Stematol. At those very high concentrations delivered IV to patients, Stematol becomes a dynamin inhibitor, and may, in fact, explain some of the side effects of drowsiness, because dynamin inhibition also slows down synaptic vesicle recycling. So the concept of this is that we temporarily trap the targets of antibodies or radioligands on the cell surface, allow, in the case of antibodies, the immune system to be activated. In the case of radioligands, to increase targeting to the proper cells, to decrease off-target effects, and also to increase the bystander effect in tumors, whereby radiomolecules attached to tumor cells can then affect the tumor cells next door. So in humans, what you can see here is this is the surface of a patient tumor before and after 20 minutes of prochlorperazine infusion. Now, this is actually a lot more complicated than it looks. People think the green here is EGF attached to the EGF receptor. This is not a change in the level of receptor at the membrane. We very clearly showed that. In this technique, which is confocal microscopy, we're using a directly conjugated ligand. And when that ligand is low density and spread out, it can't be observed because the light emitted is not enough to be collected by the confocal. We know that because if we look at these samples via 3D SIM high resolution, we can see that the EGF488 is still there. And that's published in a paper in Traffic, that initial work. So what we're looking at here is not an increase in EGF receptor on the plasma membrane, but an increase in the clustering and the availability of the target for ligand binding. So it's probably an increase in the ability of the ligand to bind, but also bringing these molecules together so that they then reach a high enough fluorescence to be able to be detected by the confocal. So in doing that, with antibodies, we were able to show a large improvement in cetuximab outcomes, in the application of avelumab. Basically, this leads to an increase in antibody-dependent cellular cytotoxicity, guided by the Fc receptor on the immune cells binding to the IgG of the therapeutic antibodies. So normal circumstances, trapping a receptor tyrosine kinase on the cell surface of a tumor wouldn't likely be advisable. All of this is done in the context of therapy. And the other important thing about this inhibition is it is reversible. So here you can see, again, time lapse, basically images taken from an application of prochlorperazine. This is anti-PD-L1. And what you can see is post infusion of prochlorperazine, the imaging on the surface of the tumor increases. But then between 2 and 4 hours, we actually see a reversal of this block whereby the antigens can then be taken up by the cells again. This is important. You cannot inhibit dynamin in humans without reversibility because it's required for synaptic vesicle recycling, and too much dynamin inhibition for too long a time would actually lead eventually to coma. So prochlorperazine has really excellent pharmacokinetic properties for the reversibility of this process. The other important thing, and this again comes to receptor levels, is a lot of people think when you inhibit endocytosis, because exocytosis to the surface of the cell would happen, you'd get an increase in receptor level. That is not the case. It's been shown in a number of applications and papers that once you inhibit endocytosis into a cell, exocytosis also stops. The reason for this is that those trafficking pathways don't just move proteins. They also internalize lipid on endocytosis, and they fuse lipid with the plasma membrane on exocytosis. And so those two pathways have to be coupled, and they're controlled and coupled by osmotic stress. Because if your cell stops internalizing and you keep exocytosing, you increase the volume of your plasma membrane to the point that the cells burst. If you keep endocytosis going and stop exocytosis, you basically get autophagy. Your cell shrinks away and loses its plasma membrane. So when we inhibit endocytosis, exocytosis is also slowed to a stop. And it's probably why our receptor levels on the surface don't change that much during that period. However, there was a paper out just after ours, Pereira, all from Jason Lewis's lab, suggesting that statins inhibiting endocytosis could actually increase the level of PSMA on the plasma membrane. And so, given our technology and seeing this, and the statins affect all endocytic pathways because they just generally affect the composition of the lipid membrane. And so we wanted to see, therefore, if PCZ dynamin inhibition could lead to increased imaging by PET. The other thing just to mention about endocytosis is a lot of these pathways have been worked out in tissue culture. We know they're quite different in vivo. And so we're in the middle of an NHMRC funded project looking at the actual pharmacodynamics of therapeutic molecules being endocytosed into cells in vivo, so that we can see what the difference rates and pathways are that clear these drugs or allow them to present on the surface. So we started with some pilot studies in adenoid cystic carcinoma in the MDA CCU1 cell line, kindly provided from the MD Anderson by Professor El Nagar. However, when we started to look at PSMA in LNCAP cell lines versus the adenoid cystic carcinoma cell line, what we noticed is the PSMA staining with YPSMA antibody seemed to be focal adhesions and not PSMA at all. So we went on to use a number of antibodies. We've actually done IP and mass spec, which is the gold standard checks for antibodies. And what we found is that YPSMA is really dirty and doesn't really see PSMA at all. J591 is an excellent antibody, originally developed Neil Bander. Neil Bander, sorry, Neil. And one of the 3E6, which was one of the commercial antibodies used for pathology, is actually okay. It's good for immunohistochemistry. So we went and searched for a therapeutic antibody, and this is why this is actually on this slide. J591 is a murine antibody to PSMA. It was originally developed by Professor Neil Bander and worked on by Pam Russell, who's in our building at the TRI. And it turned out to be acquired by Telix Pharmaceuticals in 2018. And they're a company situated here in Australia, in Melbourne. So their aim is therapy with J591, I think now developed as J592, with 177 lutetium. So we approached Telix to get some of the antibody to try our experiments. Here's J591 uptake in LNCAP cells and in MDA ACCs. Once again, we couldn't detect PSMA properly in these ACC cell lines, very clear in the LNCAP cells. So we then carried out, I say we, my PhD students Benedict Lum and James Nightingale carried out pilot PSMA PET studies in these cell lines. And what we found is that they also came up negative with F18 PSMA PET small molecules. So these adenoid cystic cell lines don't express PSMA, even though YPSMA antibody gives a positive signal on them. So we went back to the Australian Prostate Cancer Centre, and Jenny Gunter's been helping us out with her LNCAP mouse models. And the students carried out this experiment, plus and minus PCZ in LNCAP cells, and using PET imaging to see if they see any differences in the imaging collection. So what you can see here in the LNCAPs and control group and PCZ, the untreated control and PCZ, and here's tumor size, is that in this experiment, they consistently saw a small increase in the SUV max. You can see that summarized here for LNCAPs and for C42Bs. At the moment, over large numbers, we've lost that statistical significance. However, there is a large variation in tumor size in these experiments, and the young PhD students suspect that there's a size whereby you can improve the imaging and a size where you can't, and they're just working that out. So, but at the moment, consistently for patient use, the addition of PCZ to the imaging at the moment isn't going to be efficient until we work out where it should be applied. But we're looking at therapy, and we're looking at adenoid cystic carcinoma. This is our original aim. So we were lucky enough to receive a number of PDXs for the adenoid cystic carcinomas that are held in the United States. One of the reasons for continuing with this is this image, where you can see in the PCZ treated LNCAP mice that firstly, we had a longer time to image because there's a retention of the label, and so you get a longer period of imaging. But also, we appear to get reduced targeting to off-site. So it may be that the use of these adjuvants lower the toxicities to other site because they increase the targeting to the tumor plasma membrane. And so we've kind of swapped all our models around. here's some xenografts where we're now using J591 antibody from Telix. Thank you very much. And you can see that PCZ very, very much trucks that on that beautiful circular plasma membrane as opposed to internalizing to inside the cells. You can see it here. We took a prostate tumor and did ex vivo uptakes on live tumors just after removal. And again, you can see that the addition of PCZ keeps it in that beautiful round, we call them cobblestone patterns. You can see it trapped in the plasma membrane. And here by MFI, you can see an increase in the amount of J591 that can be detected on the surface of these cells, both with PCZ, but also with enzalutamide. This is not a finding that we published. This is another finding in the literature whereby enzalutamide can increase PSMA expression and actual receptor number on the surface of the cell. So we're looking at a combination of this because if we can use drugs to actually increase the receptor number, and then we can trap those receptors there for 2 to 3 hours with PCZ, we can reduce the off-target effects, we can maximize loading of these radioligands from the serum, and then allow it all to internalize into the cells. And this is a principle we're also using for ADC delivery improvement. So finally, we now have the adenoid cystic carcinoma models. We've been sent them very kindly from Xenostar in the US and the Adenoid Cystic Carcinoma Research Foundation, who helped arrange all of this. And we have them expanded, and we're just about to try a range of therapies on adenoid cystic carcinoma, including radioligand therapy. But one of our thoughts, and the reason that we're talking to Telix, is we'd very much like to try these combinations with radioligand anti-PSMA antibody, but also delivering cold antibody alongside that in order to maximize both the radio treatment and the antibody-dependent cellular cytotoxic immune response. So finally, we've had a huge amount of help from this, especially from the radioligand community around Brisbane, who have been the most generous, best collaborators ever. That obviously includes Dr. Miles Webb and John Barlow from Queensland X-ray, Melissa Latter at the RBWH. We're grateful for Telix for giving us all the reagents we've asked for. At the PA Hospital, this project was initiated and is clinically led by Professor Ben Panizza and the head and neck team there. The TRI preclinical imaging facility have been absolutely fantastic in helping us to start and interpret all this work. And of course, our own lab and collaborators who are in there putting the hours in. Thank you.